Good evening, everyone. I'm Dr. Surabhi Mitra, consultant psychiatrist at Evrox Healthcare, and also generally the moderator of this show. But today I would also be the speaker, as there would be a lot of discussion regarding psychiatry and psychology and counseling, etc. So today's episode is regarding cancer care, communication, prehabilitation, and rehabilitation. Now, we won't be talking much about what cancer is and कैसे फैलता है, क्या उसके causes रहते हैं, क्या उसका prognosis रहता है, etc. etc. Because of the very fact that हर organ का cancer cover करना would take one episode each. So today we would be strictly sticking to talking about communication with the patient, that is the doctor-patient relationship, and how it should be in India specifically, and prehabilitation is something new that you might have heard. So we would be talking about that. कि treatment के पहले exactly क्या होना चाहिए, and rehabilitation is basically treatment के बाद क्या होना चाहिए. For this, we have two speakers today. Number one is Dr. Samyadipta Dey. He completed his MS in ENT from MGM Medical College, presently working as a consultant head and neck surgical oncologist at Chittaranjan National Cancer Institute, Rajarhat. His areas of interest and specialization are oral cancers, microvascular reconstruction, rehabilitation of cancer patients. So let us welcome him, Dr. Samyadipta Dey. Hi, how are you? Uh, you're not that audible. Okay, by the time you check your audio, I will move on to introducing the next speaker. So the next speaker is Dr. Pinak Pani Kar. Completed his MDS in oral and maxillofacial surgery from Buddha Institute of Dental Sciences and Hospital, Patna. He presently is pursuing training in surgical oral oncology at Chittaranjan National Cancer Institute, Rajarhat. His areas of interest and specialization are also oral cancers, microvascular reconstruction, but also specifically dental and dentofacial rehabilitation of cancer patients. So let us welcome Dr. Pinak Pani.
Hello. Hi.
Hello, hi. How are you doing?
I'm good. How are you guys doing?
I'm doing well as well. Thank you for asking. Okay, so is your audio okay now, Dr. Day? Please unmute yourself. Please unmute yourself first. You are, but बहुत दूर से आवाज आ रहा है, ऐसा लग रहा है. Okay, maybe you can try some earphones or headphones. Okay, so till that time, I think I'll just introduce. I have already introduced the topic, but I will just introduce the app that is coming up. That is the F1 app of Evrox Healthcare. So the F1 app is basically a teleconsultation app, and it is being launched soon enough. And as you know, I keep talking about this in every other episode, that we are recruiting doctors, healthcare workers, mental health professionals, nutritionists, and whosoever basically is in the healthcare arena on this app. And definitely, I think you should contact us on the number that is given on the poster that flashes every time we present a new episode. So contact us on that if you need a demo, and definitely get your teleconsultations from all over India, and maybe you may get even international teleconsultations for counseling and etc. So please do let us know. And this message was for doctors, and for audience it is like you should just wait for the app to come out and just go on it, and you can get the doctor of your choice for consultations and at the time of your own convenience. So let us now again go back to Dr. Samyadipta Dey and just check whether his audio is has been corrected. Okay, at least I can't hear you. Dr. Kaur, can you? Okay. Uh, Dr. Kaur, can you unmute yourself so that we can just start with the session?
Yeah. Hi.
Yeah, hi. So by the time Dr. Day is back, we will just continue with the topic. So our topic today is basically communication, which is lacking a lot in India. So what is your take on the doctor-patient communication that should happen when we are dealing with a cancer patient, especially when you get a cancer patient? How do you communicate it to the patient and to the relatives?
First, when a patient comes to us, the patient has no idea what has happened to them, except for the fact that they are undergoing some condition according to the previous doctors who have told them that it might be cancer or malignancy, and the patient is in a dilemma and has no idea what is going. Uh, First, after histopathological reports or any other findings or conclusive evidence that the patient has malignancy, it is important for us to inform the patient as well as the relatives about what is actually going on. That the fact that they have cancer and it is not to be taken lightly. The fact that cancer does not mean it's the end of the world. The fact that cancer means it's a continuous fight for the upcoming days or months or years maybe, and that it can actually be cured.
Okay, so when you give the assurance of curing cancer, and if the outcome is bad or the prognosis is bad, then what do you do?
Uh, Actually, never, even at any point of time, do we tell the patient that it is 100% curable. Percentage
Yeah.
maybe around 80%, maybe around 70% assurance is given to the patient that us as surgical oncologists or the surrounding team that we have, which include medical oncologists, radiation oncologists, will work together to make sure that the patient recovers completely from our part. The rest, compliance part is dependent upon the patient, where we require the patient to be there for regular follow-ups, the relatives to comply with us in terms of regular investigations, which might be radiological or laboratory investigations, which they need to get done on time, which they need to take the condition seriously, and to make sure everything is taken care of on time. But at the end of the day, we should always make sure that the patient does not, even for once, get the idea that it is 100% curable, because at the end of the day, even God, it doesn't give guarantee. How can we?
True, truly said. Okay, Dr. Desh, shall we again check on you? Please unmute yourself.
Is it audible?
Yeah, finally. Yeah, now I can hear you.
Sorry for that. Tell me. Yes.
Okay, okay. So the same question basically we were talking about, we were just discussing about communication, which is kind of quite lacking in the doctors in India, especially when we deal with a cancer patient. So what are your comments on that? When you get a patient who has cancer, how do you deal with the communication part? How do you convey it to the patient and how do you convey it to the relatives?
So most of the problems which occur between the doctor or the patient party happens because of a lot of miscommunication. It is either a lot of under information which we give, or sometimes we overburden the patient and the patient party with a lot of information which is not required. So we as doctors should strike a balance between giving appropriate information, not giving too much of expectations to the patient, as well as keeping it semi transparent. By semi transparent I mean that the doctor should disclose information which is required for the well being of the patient. Nothing much. I mean, that should be the balance which the doctor should strike between between miscommunicating with the patient and overburdening the patient with a lot of information and using a lot of medical terms, keeping it simple and keeping it as transparent as possible, but within medical legal limits.
Yes. So, uh, do you also get patients जो बाद में बोलते हैं कि कुछ हो गया suppose, and जो बाद में बोलते हैं कि आपने तो मुझे ये बताया ही नहीं था that this may happen.
We do get that a lot, because in cancer we are dealing with things where the cancer has a high probability of coming back. There is a high probability of there is recurrence happening, and then the patient comes back and tells you that आपने तो बताया नहीं था कि ऐसे कि there is a chance that this cancer is back and is going to come back, and there is less chance of cure and all that. So in that case, this is where the problem lies. We have to make the patient understand that there is a probability, depending upon the stage of the tumor, that the cancer can come back, like a stage 3 or a stage 4 cancer, where maybe the skin is involved, the bone is involved. There is a high probability that there might be a recurrence of the cancer. So the patient should be primed a little beforehand. That's where the communication skills come in. I think, Surabhi, you as an expert psychiatrist, you are someone who can guide us. Um, that's why I didn't want you to be a moderator on the show. I wanted you to be a part of the panel, and we would like to know how should we go about, addressing a patient with a terminally ill disease, or some ailment, or somewhere where we are dealing with a serious disease like cancer. So how should we
Yeah.
go about addressing the patient? How should we go about breaking the bad news? So please go ahead.
Even in psychiatry, we definitely, you used the proper word, semi-transparent, that you needn't need complete transparency. I hope I'm not breaking or my voice isn't breaking.
No, it's absolutely fine.
Okay, fine. Yeah. So in psychiatry or in psychological counseling, we definitely use the same thing, that is semi-transparency. We don't go about telling the patient each and every aspect of the cancer, कि exactly कहाँ है, कितना बड़ा है. That is the duty definitely of the treating oncologist. But when it comes to communication, you have to see that the patient does not lose hope, because once that happens, as you know, or as is rightly said, बहुत बार हम ये कहते हैं कि हर जो डिजीज होता है टर्मिनली इल पेशेंट का, that is 40% a physical ailment, but 60% it is governed by the psychological factors. And psychological factors matlab, if the patient is losing hope, if the patient does not want to come for treatment, then it will cause a lot of problem with the compliance. The patient will not be compliant with the treatment. वो आएगा नहीं, वो वापस डॉक्टर के पास जाने के लिए डरेगा, वो अपने मेडिकेशंस प्रॉपरली लेगा नहीं, वो सर्जरी के लिए जाने के लिए डरेगा अगर सर्जरी जरूरी है तो. देन रेडिएशन कीमो के भी बारे में जितना बताना चाहिए, we overexpose them with so much of information that they start fearing going for radiation and chemotherapy, even if it in some cases it can even be curative to certain extent. Again, I wouldn't use the, as Dr. Pinak Pani said, that we shouldn't use the word 100% curable, but To some extent, definitely, it helps in postponing, I may say, fatality, or increasing the lifespan of the patient to quite an extent. और जब वो रहता है तो उसके बावजूद पेशेंट को अगर वो समझ ही नहीं आ रहा है कि उसके फायदे क्या है, if the patient is not coping up properly, then there is no use of this chemotherapy or radiotherapy. Even if we give it to them, they won't be, responding to it quite properly. So if their mind is not prepared for it, their body will not respond in a positive manner to whatever treatment we give, be it radiotherapy, chemotherapy, surgical therapy, or medications what we give. So yeah, this is something that is to be maintained, especially in adults. I would say in geriatric patients. सबसे ज्यादा जीरियाट्रिक पेशेंट्स मतलब ओल्ड पेशेंट्स जो रहते हैं हमारे, उन्हें जब कैंसर होता है तो उन्हें ओवरबर्डन अगर कर दो इंफॉर्मेशन के साथ, तो उनके मन में सबसे पहले ये ख्याल आता है दैट I am as it is old. I'm as it is going to die soon. What is the need to go and take cancer treatment? Probably this cancer was supposed to be God's way of telling me कि अब जल्दी आ जाओ. Such thoughts come to geriatric patients or old patients many a times, and that is the reason they don't prefer therapy at all. Secondly, they don't prefer going to psychiatrists or psychotherapists because they feel कि मुझे कैंसर ही तो हुआ है, मैं पागल थोड़ी हुआ हूँ, so why do I need therapy? But then we need to tell them that this is for building their coping up mechanism for daily life, be it before treatment or be it after treatment. We would definitely be coming to prehabilitation and rehabilitation, for which major counseling is needed. So I will hold on for now and I'll continue about this later on. But I'll just give a brief about this, that proving helping them in building coping up mechanisms before the treatment starts is more important. And being a source of support, being a source of encouragement, being a support, being somebody who is affirmative in their life is very important. So this is how we start, but I think I will wait to continue on for later. So now that we have talked about communication and the basics, लोगों को प्रीहैबिलिटेशन क्या होता है ये पता नहीं, एंड आई वाज टोल्ड दैट डॉक्टर पीनाक पानी कौर वुड लाइक टू डेफिनेटली टॉक अबाउट प्रीहैबिलिटेशन in detail. So please go ahead and let us know what prehabilitation is.
Yeah. Uh, Basically,
Yes, sir.
prehabilitation. Yeah.
Yeah, please continue.
Prehabilitation is basically what happens before the treatment part begins. That is basically since the patient has received the information or the news that this has happened to them, from then on till the treatment has begun or the surgery begins. That is, it can be divided into psychological phase where the patient is mentally preparing themselves for what is to come. It can also be included as the physiological phase where the patient starts training their body in the ways that they will have to later on when the treatment has already begun or the surgery has already taken place. That is, the patient can visit places like the psychiatrist or the psychological counselors. The patient can visit the patient can be guided to be taken care of by a speech therapist, by a swallow therapist, people who will actually tell them or inform them about what is to happen and how they can cope up with the situation. No, I can't hear you. I can't hear you.
Okay, now, yeah, Dr. Day, would you like to add to what Dr. Pinak just said?
Yes, Dr. Surabhi. Uh, Before I come to prehabilitation, there was a question which came to my mind. Is that
Sure.
still going back to communication, yes, you have stressed on these facts that we need a good support system for the patient. We need to give him confidence that the definitive treatment that he's going to undergo is the best for him. Also, we need to give him options where where the patient sometimes doesn't give consent for a treatment, he can also go for number 2, number 3 treatments, where the results may not be as good as number 1. But that is where an adult patient can take a decision for himself. That is where the patient's kin can also take a decision. But we do get a lot of hematological cancers. We do get a lot of children with hematological cancers. Does the communication stay the same? It does the do the uh, do we communicate with them the same way as we do with adults?
No, so there is definitely a difference in between communicating with a pediatric patient, that is a bacha, and an adult. So when a pediatric patient comes to us with so and so issue, the more the quantity, I would say, the quantity as well as the quality of distress is seen far more in their parents as compared to the child, because the child is not that aware of the situation. चाइल्ड को बेसिक कैंसर क्या होता है से शुरुआत करनी पड़ती है, वो भी उन्हें नहीं पता होता है. सो व्हेन दैट हैपेंस, व्हाट वी डू इज, जितना जरूरी है उतना भी आंसर, एंड जनरली वी टॉक टू द पेरेंट्स फर्स्ट. सो व्हेन वी टॉक टू द पेरेंट्स फर्स्ट, पेरेंट्स जनरली टेल अस कि हमारे बच्चे को आप इससे ज्यादा मत इंफॉर्मेशन दीजिए, बिकॉज यू नो उसे या पहली चीज तो समझेगा नहीं, दूसरा समझ भी गया तो probably the child will lose hope. The child, and if the child loses hope, the quality of life will deteriorate. So this is what happens. Secondly, it also depends on the staging of cancer. अगर बहुत ही अर्ली स्टेजेस में है तो काफी बार पेरेंटल काउंसलिंग से भी बात चल जाती है, ओके. बट अगर लेटर ऑन स्टेजेस में है, so we do definitely sit down with the child and talk to the child depending on the child's age and the child's IQ. So बच्चे की एज अगर 6 साल से कम है, so generally we try to convey the child with play therapies. So play therapy is something जिसमें there are models of there are dolls, there are different models like sand play, etc., etc. A lot of things are there, and we try to communicate through those models कि अगर ऐसा हो जाएगा, so what will be the reaction of the child, and generally the child reciprocates or reacts through that play therapy itself. तो प्ले थेरेपी के थ्रू हमें समझ में आ जाता है कि हाउ मच ऑफ coping up mechanism would be useful for this child, a particular child, and every child is treated individually. Generally what happens is हर एडल्ट को हम लोग एक जैसा ट्रीट करते हैं, कैंसर पेशेंट, इफ यू हैव सीन इन जनरल, but every child is treated as a special patient. Every child is treated as a different patient. So as I said, in that sense, then again it depends majorly on the communication with the parents. Now the parents are the ones who give the consent, be it for chemotherapy, radiotherapy, surgical therapy. They come across the options, they decide. But if the child is generally above the age of 12 years, so 12 to 16 years ke age mein, even the child's opinion is considered. Not that the child can give assent, but the child cannot, I mean, the child's opinion is taken into consideration, and 12 से 16 साल के बच्चों को जितना वो क्वेश्चन करते हैं उतना बताया जाता है. सो स्पेसिफिकली इफ दे क्वेश्चन अस कि अच्छा मुझे कैंसर हुआ है, कौन से पार्ट का है, इसका क्या मतलब है, ये कैसे स्प्रेड होता है, व्हाट एग्जैक्टली इट इज, सो वी जनरली ड्रॉ इट on with pen and paper, and we explain कि ऐसा ऐसा है, ऐसा ऐसा फैलता है, you know. And and ये बच्चे काफी बार समझ भी जाते हैं, and a lot of times children between the ages of 12 to 16 have good prognosis as well. So we tell them prognosis wise कि कितना है कैसा है, and they understand. A lot of times I have seen that they don't lose much hope. So then we talk about how they can cope up, and then we give them affirmations. अब affirmations कैसे रहता है, you know, कि come what may, you will always be loved. Come what may, you will always be cared for. Then we tell them, you are strong, you are full of hope, you are inspiring, I am proud of you. You know, we teach the parents to use such affirmations in day-to-day life. And हमारे therapy sessions में भी we do the same, you know, that you are being brave, you are full of hope, you are an inspiration to even me, things like that. If a therapist or a psychiatrist says such things to the patient, to the बच्चा, तो बहुत फायदा होता है to their psyche. So this is a general lookout as to how we go about it. I hope I could
So
answer it, but
yeah, that was
future,
wonderful. That was wonderful. As you rightly said that yes, treatment is necessary for treating cancer, but hope is something which keeps the patient alive. I think
absolutely,
that is that is very important, and that hope should be given by the person who's treating the patient as well as his support group.
yeah, especially the parents and the
Yes,
family members. And generally जो 12 से 16 के बच्चे होते हैं, the elder category, you know, they have a close knit friend circle as well. So the friends, when they come for meeting the patient, you know, sometimes even they want to talk to us. And the close friend circle जब आता है बात करने, तो हम उन्हें भी ये सारी चीजें सिखाते हैं,
exactly, exactly.
because that forms the
Uh,
child's peer group, and peer group is very
yes,
important.
yes, yes. But do you think, as like um, we have
I think
the
today, Dr. Day, you are the moderator.
okay, fine.
No, no, no.
You are
It's amazing. I am liking
you're
it.
on you're on the hot seat today. So so no, what I was thinking was that whether we have all worked in a government institute some time or the other, and where where we have one patient and 5 or 6 people with the patient. Sometimes the whole mohalla comes with the patient.
Yeah,
So
yeah.
is it? Do you think that it is? You know, uh, the communication should be with only the kin, just the very kin of the patient, the like a wife or the father, or we should all address the whole support group that has come with the patient, or keeping one patient party communicate everything to that patient party, and that party communicates with the whole group. Which what do you think should be the should it be like?
So I think it is very important to identify who is close to the patient. Okay,
Exactly.
even if it is not next to kin, or even if it is not the, you know, the only family members or only typically parents, even if it's not that, we should be able to gather information and be able to observe basically who is closer to the patient. And in such case, because many times what happens, for example, what a father cannot convince, probably a close friend might be able to.
Exactly.
Okay.
Yeah.
What a grandfather may not be able to convince, probably a sister might be able to. What a sister might not be able to convince, probably a girlfriend or a boyfriend or a partner might be able to. Okay, so we don't know. So once we identify the core group, see, it is important to convey important information, that is like very, very basic information टू द फैमिली मेंबर्स, वो तो करना ही है, पेरेंट्स को तो बताना ही है, क्योंकि कंसेंट अल्टीमेटली वो ही देने वाले हैं। बट डेफिनेटली जो पेशेंट से क्लोज है और जिसका पेशेंट सुनता है, सबसे इम्पोर्टेंटली जिसकी पेशेंट मानेगा कि हाँ बेटा कीमोथेरेपी को जाना है अपने को, इट विल हेल्प यू, रेडियोथेरेपी को जाना है, इट विल हेल्प यू, प्रोबेबली द सर्जरी विल हेल्प यू, these are the options, this is the menu, let us see. So जो ये कर पाएगा उससे बात करने में कोई हार्म नहीं है. So I don't think that we should leave it up to the parents or the family members to convey to the mohalla or the support group. I think we should be the ones who should be conveying it to the support group, because we are the proper persons who know what is it and what it can be.
Absolutely, absolutely. So, Pinak, any questions about communication you have? We do have a lot of challenges in communicating with the patient. I don't
I
really
know.
feel that I really
मुझे
feel
बुला लिया
sometimes
करो.
absolutely you should be on video call with us when we are counseling a patient. We
Yeah.
sometimes we understand that we are doing injustice to the patient, that we do not hear the the complaints of the patient well, or the
Yeah.
concerns of the patient well. Before, like today, when I was going on my rounds, this patient, it was a very advanced disease. Just to cite an example, it was a very advanced disease. The patient is going to get half of his cheek cut, half of his half of inside the whole buccal mucosa, the inside of the cheek, everything is going to be resected, and we are going to put in a free flap, or we are going to put in a skin graft or something like that. Okay, a pedicle flap. So the patient was not concerned about the cancer. Patient was more concerned about the aesthetics.
Exactly. That happens.
How will I face my neighbors? How will I face my the family members are going to stay in my house? Sometimes you find it very difficult to answer these questions, because you have to understand what are the rehabilitation goals of each patient are different. So listening to a patient, I think, helps. Sometimes we don't allow
Yes.
them to speak. We just burden them with a lot of medical jargon, and we just explain to them that these are your options, and इसी में करना है आपको, and this is it. We don't listen to them. So
So
that
that
is,
is
I
what
think,
I exactly say, that the word empathy should be everywhere. So if we really go into the shoes of that patient and understand their concerns, that really helps in the counseling or in answering their questions or in even basic listening to them. A lot of patients, as you rightly said, are not concerned with the cancer per se, but they are concerned with the cosmetology. What will happen? How will I look? Will I be desirable? Will I be loved? Will I be attractive? Such questions pop up in their head. A lot of times there is a lot of regret also. Say, for example, the cancer has been caused because of, or presumably because of excessive tobacco chewing or smoking or whatever purpose. Okay. So, or excessive alcohol consumption, जो भी हो. So, a lot of times there is a lot of regret also. You need to be empathetic towards that regret as well. You shouldn't be scolding the patient. क्या तुमने एक एक बम पर रोज दारू पी इसलिए तुम्हारा लिवर सड़ गया, क्या तुमने टोबैको च्युइंग किया दिन रात इसलिए तुम्हारा अभी जबड़ा हटाना पड़ रहा है, जॉ रिमूवल करना पड़ रहा है. So this is not how you talk to a patient. You just say that bygones are bygones, now is a new life, now let us see how you deal with it. And generally वो regret की वजह से, वो guilt की वजह से, the patient generally leaves everything. And if we scold them, they may again start with the substance abuse. So there is a very fine balance in between this. So we should be able to balance the scolding part as well. थोड़ा बहुत डांटना ठीक भी है, but we should be more empathetic towards the patient. And yes, listening is very important because cosmetologically हम लोग ज़्यादा सोचते नहीं है. हम लोग सोचते हैं कि why isn't the patient more concerned about the cancer treatment? Why is this patient asking me as to whether I would look attractive in the future or not? No, probably the patient is okay with living a life of maybe 1 or 2 more years, maybe not 10 years or 20 years, but the patient wants to look good in those 1 or 2 years. So we should be addressing that.
Sometimes it becomes difficult to give, uh, the quality of life which the patient expects post treatment.
Yeah, are you back,
Can you hear me?
Dr. Day?
Yeah, I'm here. Can you see me? Can you hear me?
Yes, yes.
I think Surabhi is having a problem.
Okay, I think there is some technical. Okay, I think he's back.
You can see me now?
Yeah, yeah, we can see you, we
So,
can hear you. So I hope
yes.
you understood. I mean, you got my answer.
Yes, we should strike a balance between sternness and showing also some empathy for the patient,
Yeah.
where the quality of life which the patient expects that he or she will have after treatment and what we can actually provide, that gap should be closed with communication.
Yes,
Because
because yeah, please continue.
there is a lot of, I feel there is a lot of over expectation that the patient has. The patient expects to eat everything, whatever he used to eat. He doesn't expect to be on a rail stool for all his life. He wants to breathe like a normal man, but still he's on a tracheostomy tube where he can't speak. Yes, there are speaking
Hmm.
valves, but still, communication becomes a problem, swallowing becomes a problem, aesthetics become a problem. People just maybe he can just become a taboo in the society that this person doesn't look normal. So that sometimes patients have over expectations of the quality of life which they expect and what we can provide. So that thing should be very important that that line of that channel of communication should be clear enough where the expectations are
Yes, I will.
addressed.
I will give you. Uh, yeah, I will give you a simple example. We had a patient who, who had uterine cancer, but also was pregnant at the same time. So to save the mother, it was important to do a complete hysterectomy, and the child was not to term. So I mean the fetus, sorry, not the child. The fetus was not up to term, and the it was important to tell the mother that either you can keep the child and you may pass away because of cancer, okay, or you may do complete hysterectomy and live a longer life, but then you cannot expect that you will have your own uterus or you can bear children in your own body. You can later on have options of adoption and surrogacy and all of that, but you cannot feel that pregnancy in your body.
Hmm.
But that patient still chose to go ahead with the pregnancy and not do a hysterectomy, and the patient was okay with leaving the child to be reared or taken care of by the father even if she passes away, but she wanted the baby to come on the planet, and it was okay with her if she doesn't live anymore. So you have to consider these things also, कि patient
Hmm.
को क्या चाहिए.
Exactly. Most of the times we kind of impose our uh,
Yeah,
goals on the
because we
patient.
think very logically. वी थिंक कि अरे क्या
Exactly.
है, एक एडॉप्शन कर सकते हो, सरोगेसी कर सकते हो और बहुत कुछ कर सकते हो. व्हाई डू यू वांट टू फील द प्रेगनेंसी इन योर बॉडी? यू कैन सेव योरसेल्फ, you can still have
Mm-hmm.
children of your own, you can still have a big happy family. But no, sometimes we can't understand, we can't exactly go into their shoes and actually try to gauge कि क्यों इनके लिए ये इतना important है.
Okay. So I was going through a paper where uh, I understood there were 5 E's of basic communication. So whatever we spoke about right now, I think those 5 E's are very important. One is that we engage the patient. Okay, we engage the patient means that we hear out what are the patient's concerns. Let her or him talk. Let us listen to what that person wants to say. Okay. Next is elicit the patient's understanding and concern. What is the patient's? You will be talking in big medical terms. We'll be cutting this, we'll be cutting that, and ye chemo milega, aapko, wo milega. But what is the patient understanding? What is he? What are his or her concerns? Educate the patient. Okay. So education मतलब ये नहीं कि एकदम उसको डॉक्टर बनाने का, ऐसा नहीं. मतलब you have to somewhat kind of a middle ground where he also understands, and it's also easier for you to talk to him or her. Address emotions, empathy, empathize with the patient always. Enlist collaboration of neighbors and caregivers. So there are 5 E's: engage, elicit, educate, empathy, enlist.
Yeah.
So yes, if we can remember those, I think it will make our job easier. It will also decrease the miscommunications that we have. We hear these incidents where the doctor gets beaten up by the patient attendants and parties, and they say that doctor ne nahi bola mujhe.
Right.
I think we can just a small thought that we can do a lot by just listening and talking to the patient. Give a
Yeah,
little
I
bit of
think.
your own, give a little bit of your own, busy schedule to just. There should be a time like a 1 hour or something where you just can talk, where a counseling room, a happy environment where you can just talk to the patient and patient.
Yeah, many a times the reason of violence against doctors is bad communication.
Exactly.
So, yeah, what you said is very important. And even after that, I say that, say, for example, uh, an oncologist is so busy that he's seeing, say, for example, 20, 30, 40, 50 patients a day and is not able to be there for counseling of every patient. So, I still think that if the oncologist is not available, but at least there are specialists who are available specially for this counseling,
Mm.
so why not utilize them? Why are we wasting that resource? We are wasting, there are so many psychologists, so many psychotherapists, so many psycho-oncologists, so many psychiatrists who are there, and we are not using that resource, that abundance of resource.
Yes.
So I think
Yes.
why not utilize that in every
This
on
is
every
happening
patient?
in. This is actively happening in TMH Mumbai, that I know, but and this is also very common practice in the Western world. But still, we don't think communicating with the patient is important. Still, at least in Eastern India, I feel that our side of the country or the rest of the country, we still feel that we are doing a favor for them. I mean, we are doing a favor on them by treating them. Because that
Yeah.
shouldn't be the idea. That shouldn't be the idea. Have a psychologist team working on your patient. Have them undergo a questionnaire. Have them undergo a session where they can address their concerns. So what we were talking about basically is prehabilitation, where basically what Pinak was also saying. we are priming the patient beforehand, before we start the treatment, way before we start the treatment. So prehabilitation basically starts once we have examined the patient, we have diagnosed the patient, we have done proper staging of the patient, and we have placed the patient in the tumor board. The tumor board decides the treatment of the patient. Yes, surgery, yeah, the patient goes for chemotherapy, radiotherapy, whatever, neoadjuvant, whatever. But the, the making the patient ready for the, you know, every definitive treatment in cancer is associated with a lot of toxicity. You undergo surgery, you come out with a, half your face covered with a skin flap, whatever. You come out of chemotherapy with a lot of infections. You come out of radiotherapy with, darkened skin, and patient can't swallow. Patient has mucositis. Patient has the whole oral cavity is burning. Patient can't even have a normal life. Yes, yes. So the prehabilitation should start from there. So prehabilitation should start when the patient has been diagnosed properly. The tumor board decides, and then there is a team of people, as you said, Dr. Surabhi, that there should be a team of psychologists. There should also be a team of people who take care of the patient when he has been diagnosed and is going to undergo some kind of treatment. So that team, that core team, will consist of dental rehabilitation. Okay. So dental rehabilitation, why? Because Pinak can give sight a lot of light on that. But most of the patients who come with cancer, oral cancer specifically, they come with very bad oral hygiene. The dental hygiene is so bad that sometimes we have to send the patient to the dental person, and the dentists remove a lot of teeth before the patient undergoes any kind of treatment. Because if we suppose the patient undergoes some surgery and then undergoes radiotherapy, any kind of gingivitis, any kind of caries, dental caries the patient has, the patient will land up with a whole infection of the whole bone, and that is called osteoradionecrosis, and it's a very bad state to look at. So, Pinak, uh,
Yeah.
please talk about a little bit of how to go about dental rehabilitation before every surgery or anything. We send the patient to you, okay, and then you look after the patient, and then you look at the patient. You get a what all do you do? How do you prime the patient perfectly so that the patient can undergo some kind of treatment?
When it comes to talking about the dental aspect of oral cancers, it can be divided into the prehabilitative as well as the as well as the rehabilitative phase. In the prehabilitative phase, the patient is first informed about the fact that he or she might be losing out on a part of their jaw or entirety of their jaw, or they might lose function of their tongue, or they might actually have to get most of their teeth or all of their teeth extracted. Basically, this is going to affect the quality of life in terms of nutrition, in terms of aesthetics, in terms of function, in terms of other aspects such as temporomandibular joint disorders, etc. At the same time, the patient should be, once the patient is aware that this might happen to them, or in due course of time during the treatment post surgery, the patient might undergo radiotherapy or the patient might undergo chemotherapy, whereby the patient will actually be facing a lot of other issues like mucositis. The patient might, if they undergo any dental procedure post radiation, they might undergo osteoradionecrosis. The patient needs to be aware about this fact. And based on this, the patient needs to understand how important dental hygiene is when it comes to oral cancers, or when it comes to basically in daily life. In case of oral cancers, we as surgeons will take care of the oral condition along with associated with the cancer, that is any other tooth which might be affected by caries, or any other tooth which might have undergone abrasion, which might have undergone attrition, which might in due course of time need other treatments, dental treatments like root canal therapy or fillings. These all are addressed before surgery. In case of extractions, we usually prefer to get the extractions of teeth done during surgery, so that the patient doesn't have to undergo another bout of local anesthesia and pain and all those before the real game starts or the real surgery begins. This is all performed in the OT under the general anesthesia setup, and it's all taken care of. And post surgery, the patient really needs to understand when there is trismus, when there is reduced mouth opening, when there is actually condition in which the patient has to undergo enteral nutrition through the Riles tube. The patient has dry mouth. The patient has condition. The patient is unable to open their mouth. They have no idea what is going on. They are actually in a lot of pain, and the oral hygiene needs to be maintained. In that case, if not the patient, at least the caregivers, at least the people who are there by the patient's side, they need to be informed how this should be taken care of. Like if the patient is unable to brush properly, at least they can their mouth can be cleaned using a wet gauze, or their mouth can be cleaned using saline irrigation or using mouthwash irrigation. At the same time, when it comes to cases where the entirety of the mandible might be removed, or we are using an osteomyocutaneous flap for reconstruction of a condition where the mandible has been taken out, we as dentists or as maxillofacial surgeons who have dental background, we understand how important teeth is for a human being. We know that implant placement actually helps with the patient, helps with in the future, in the long run, for the patient, where after say surgery, if the patient has to undergo radiotherapy, maybe for the next 2 years the patient will not have any procedure done on them. But if we are able to place an implant or dental implants on the fibula which has been extracted, or the iliac crest bone that has been extracted and placed in place of the mandible, we know or we understand that situation that we have created in the OT is going to help the patient in the long run, maybe 2, 3, 4 years down the line, when the patient is disease free, when the patient has no sign of or evidence of locodiginal growth of the disease or recurrence of the disease. The patient can actually get their teeth replaced in the form of individual teeth, or maybe in the form of a complete denture, and hereby the form, function, aesthetics can be addressed. And these all need to be informed to the patient beforehand, and this is basically where dental rehabilitation or dentofacial rehabilitation comes into play in case of oral cancers.
So this was the dental aspect of it, where you help the patient to basically chew after treatment. Half of the patients can't even chew half of the whole
They
jaw turns to one side, and
have some of their muscles, they have reduced, they have no understanding or control of their tongue or of the remaining part of their mandible. That is where this
so
actually
exactly.
helps.
So rehabilitation will help the patient understand that post-operatively they would be facing these problems.
They need to be
So
informed, they need to be aware of the fact that this might or this is actually going to happen, and based on that they can take conscious and decisions based on upon the fact that they were actually aware of these informations. And accordingly, if accordingly such hasty decisions like getting an extraction done 2 months after radiotherapy can be prevented, and thus we can prevent conditions like osteoradionecrosis and other things that can be like avoided easily.
right. So Dr. Surabhi was talking about psychological counseling of the patient much before. I think we have one psychologist today in the audience. She's my known, and Dr. Surjo Shikha. Can she be brought on the line? Admin, is it possible? I see her in the audience.
Have you sent the link of the studio
Yeah,
to her?
yeah, yeah, yeah. The link has been sent.
Yeah.
I think there are issues where, okay. So let her come back. So prehabilitation, as I was saying, that it is done by a group of people. So one is obviously dental prehabilitation. One is done by the psychologists. So we have started a small pilot project where uh, there are a lot of quality of life instruments around the world. Okay, one of them is the Washington Quality of Life Instrument, where we measure the anxiety, say, like stress, the speech, the swallowing, everything. There's a like I think there's a two-page questionnaire on which the patient is assessed, and there are a lot of other quality of life assessments like ECOG and everything. So, but in India we lack that. I wanted to start this where uh, we also do something like this, where a patient is made to sit and under write or submit a questionnaire. Where, so Shurjoshika is a big part of that, and we she comes online. Then I think we'll talk about that. The third is the nutritionist, where the patient is in the prehabilitation stage before the treatment starts. The patient is assessed whether the patient has proper BMI or not. A height weight ठीक है कि नहीं, that's because most of the patients can't even eat because of the oral cancer they have. They can't even chew their food. So the patient loses weight. And if the patient has low BMI, the patient is not able to undergo any kind of treatment. So nutritionist is a major part. Just the assessment part. The later, obviously, they will supplement the patient with whatever nutrients are required, carbohydrates, protein, amino acids. They will be doing that. But that is very important. The fourth most important member of the group is a speech and swallowing pathologist, SLP, जिसको बोलते हैं. And that's also these days we call them deglutologists. So this is a science which is coming up, and where we assess the patient with something called FEES, FEES. So it's the functional endoscopic evaluation of swallowing, where endoscope is put through the nose, and the stages of swallowing are recorded. So to put it in very simple words, it's a very complex thing, but that's how a deglutologist helps, because the does swallowing and aspiration, these two are the major enemies of a patient who undergo any kind of surgery or radiotherapy or chemotherapy. And in the end, the other important member of the group is a physiotherapist, where a physiotherapist guides the patient on, basic strengthening exercises, very basic strengthening exercises, like just flexing the muscles, or also like kind of priming the patient that after surgery they are not going to be this ambulatory as they are now. So priming the patient, how to use their muscles beforehand. So that also becomes a very important part of prehabilitation. I have a video. I think I told Surabhi about it, and we'll play a small video, which this is how things are done in our institute, where the physiotherapist is educates the patient. So yes, Surabhi, back to you.
Yeah, Dr. Surja Shikha is here. So, but
Can
her
she be
device
brought
is not
on? Can she be
connected.
brought in the panel? No.
Her device, it says her device is not connected as of now. So yeah, I think admin, by that till that time, can you play the video that was sent by Dr. Day?
Admin, I know the video is pretty long, but we would just a minute of it. I think to get a essence of uh, how physiotherapists help cancer patients every day.
एक्सरसाइज में क्या कर सकते हैं ये हमारा हेडलाइन के पेशेंट इनको थोड़ा जो है ये आपको बताएंगे
I think admin, the video is buffering a lot. I think we cannot get a. Are the others able to see it?
No, it's buffering a lot.
No, I think there's an internet issue. This is a wonderful video. If you could have watched it.
3 4 5 6 7 8 9 10
I could only hear the audio. The video was not proper.
Yeah, the video was stuck.
Yeah.
So there are these passive and active exercises which the physiotherapist makes the patient do. So these are called isotonic and isotropic exercises, where each muscle group of the body is activated and basic exercises like as you saw that that flexing of the neck and flexing of the shoulders, because uh, what happens is when we operate, I'll just give an example where in the neck there is a nerve called spinal accessory nerve. Okay, and this nerve is commonly injured where, not very commonly, but yes, it does get injured while doing a neck dissection. Now this spinal accessory nerve, it actually uh, it helps the arm to go above the shoulder. Okay, it supplies the trapezius muscle and it helps the arm to, you can raise it above your shoulder level. So when the spinal accessory nerve gets cut, then the patient postoperatively has shoulder syndrome. So where the patient is unable to raise the arm, unable to wear a shirt, unable to pick something up from above and keep it below. So these are the handicaps that patient undergoes. So a physiotherapist's role becomes very important in these cases where he can slowly understand that what is the problem and the exercises which he does need to do which to overcome this abduction problem. Slowly the nerve function comes back, and then maybe 100% there is no 100% recovery, but at least if the patient can regain 60% of the function, I think the job is done. Psychologist, I think our Joshika is having issues with joining in. So, Surabhi, I think we can continue with that, with the next topic.
Okay, so I think we have finished with prehabilitation, rehabilitation as well. What would you want to pick up next?
So, rehabilitation may the prehabilitation part is gone, and then now the rehabilitation part may. I think Pinak, is there any? Are there any? No, what changes in the rehabilitation? Rehabilitation, so you are priming the patient. Okay, you are making him ready for what he's going to undergo. It's like a bomb hitting the patient. Okay, it's like probably a nuclear bomb hitting the patient. Okay, and you are making him prepared for that, for the calamity. what's now once the patient undergoes treatment and he is in a lot of pain and he's in a lot of misery, what is the change that we do in rehabilitation? How do we rehabilitate that patient?
The most important rehabilitative condition that a patient needs to get addressed is reduced mouth opening or trismus. It happens after almost every oral surgical procedure or regarding oral cancers, because somehow or somewhere or the other, some or the other muscle of the mouth, around the mouth or the oral cavity, which helps in the opening or the closing of the mandible, is affected by the lesion and needs to be addressed. Hence, after surgery, the patient usually undergoes this condition called trismus. Trismus is not something that a patient can take care of by himself or by herself, because it is basically the mouth is shut. There is no opening,
Okay,
and
so we have a lot of non-doctor friends.
yeah,
We have a lot of non-doctor friends. Explain what is trismus.
trismus is basically when the muscles which help in chewing, like muscles which help in elevation of the mandible upward, closing with the maxilla, where the teeth come in contact with each other. That is when the muscles get into spasm and are unable to easily contract and relax, helping in the opening and closing of the mouth. Hence, the muscles are in spasm, and there is completely shut mandible in contact with the maxilla, and that is basically called trismus or reduced mouth opening, zero mouth opening basically. In that case, the
Okay.
patient needs this condition needs to be addressed very early, because if it persists for a long period of time, the patient will actually have trouble opening the mouth in the future. Post operative, day 3 or day 4, we actually, in fact, day 2 only, we ask the patient to start opening the mouth slowly. If possible, they can take, if possible, only one finger at first, followed by more if they can adjust at that particular point of time.
I think you also use ice cream sticks to
Yes, sir. Yes,
also
sir.
help the patient.
It
It's a
can
very common
actually,
thing. Yes.
yeah, yeah. It is a very useful thing for us, because when the patient undergoes trismus, we ask the patient to take ice cream sticks and put them between their teeth, because ice cream sticks being made of wood, they are actually spongy in nature when it comes in contact with the tooth, and it is not as hard as a metal substance and does not actually cause any trauma to the patient. It
Mm.
is soft actually when they feel with their teeth, and thus by placing an ice cream stick, and even if they want to close their mouth or keep it shut in case they are going through some pain, they can actually do that without going through some dental trauma, or without feeling pain.
So we can have you have I believe that you have a instrument, a mouth opening instrument
We
called
have
hissers.
Heister's mouth opener, we have Doyen's mouth openers, but
Those are made of
those
steel and they can cause trauma.
yes, those need to be activated, and they need to be placed between the upper and the lower set of teeth. For that, we need a basic amount of mouth opening, which can be attained by placing these ice cream sticks initially, maybe 5-10 ice cream sticks. Thickness amounts to around 1.5 centimeters, where we can place the other mouth openers and in due course of time activate them and help with the mouth opening of the patient.
So we also have cases where we remove half of the jaw of the patient.
Yeah, yeah. In that
Okay,
case,
so
guide flanges
in
can
surgery,
be
surgery we
customized.
call that mandibulectomy, and we remove the half of the jaw very happily. Now, but the problem is what happens is after that the jaw, the normal side of the jaw, it swings to the side which is
Other
resected. Okay, that is because of the unopposed action of the muscles. Now, how do we treat that? Because the patient cannot, with that, every time you open your mouth, your jaw basically swings to one side. So the patient cannot chew, the patient cannot swallow. How do you treat that? How do you, are there any things where, where we can help the patient, such
prosthetic appliances, there are certain prosthetic appliances which can help. For example, a
patient?
guide flange, which will help to guide the teeth or guide the remaining portion of the jaw into two go back into occlusion where it initially was before the mandibular or the hemimandibulectomy was performed or the segmental mandibulectomy was performed. And thus the teeth usually see. For this, we need to understand, have a basic understanding of occlusion. That is how the teeth come in contact with each other. They are not haphazardly arranged. They are basically, there's a particular set of uh, method by which the teeth come in contact with each other, and that is understood by people who are in the dental fraternity, us surgeons, prosthodontists. They know it better than us actually. And post surgery, we send such patients to the prosthodontists who design such guide flanges, which help to uh, which
Align
help
the jaw.
to basically, it helps the muscles remember how to function even in the absence of the other side of the mandible, and help bring the tooth back into position where it originally was.
Nice. So yeah, so that is dental. Coming to
Yeah.
Surabhi, what changes? What for you? What should be the changes in the rehabilitation be? Like in the post-operative period, post-treatment period, what should be the how rehabilitation is we are doing whatever priming and all, but rehabilitation where the patient does get depressed
Yeah.
when he understands that that this is the life which I will be living for the rest of my life. So
Yeah, so
he goes
in
under.
our rehabilitation counseling, there are a lot of things that come into picture. First of all is the quality of life expectation. So प्रीहैबिलिटेशन में तो डिस्कस होता ही है कि क्वालिटी ऑफ लाइफ एक्सपेक्टेशन पेशेंट की क्या रहेगी पोस्ट प्रोसीजर, बट एक्चुअली क्वालिटी ऑफ लाइफ बाद में क्या है एंड पेशेंट उससे कितना सेटिस्फाइड है is something which is to be discussed with the patient. So that counseling is necessary because a lot of times we make them fill out quality of life scales and quality of life questionnaires, and we also talk to them about this. Wherein a lot of times they come up with this कि जितना भी हमने expect किया था उससे हम कम satisfied है, and that causes despair, that causes depression, that causes anxiety. So that counseling is needed, ki how to manage themselves with now the current quality of life and what to expect after this, कि इतना अगर आपने मैनेज कर लिया तो इसके बाद आप क्या एक्सपेक्ट कर सकते हो, दूसरा मैनेज करने के बाद आपकी क्वालिटी ऑफ लाइफ कितनी इंप्रूव हो सकती है, कितने परसेंटेज से हो सकती है. This is the guidance that we can give. Then next we also talk about pain counseling, because cancer patients go through a lot of pain even during their prehabilitation stage, their rehabilitation stage. So we talk about that. We talk about their drug choices. We talk about उनको क्या सूट हो रहा है क्या नहीं हो रहा है. Secondly, we also talk about how they can mentally manage their pain, as in how they can cope up with the pain through self counseling and mindfulness. Now, what is mindfulness? Mindfulness is basically being aware of what is happening, being aware of yourself, your own body, and your own surroundings. And mindfulness techniques use karke how they can manage pain. So we teach them that. Also, something that is very important is terminal counseling. Now, say for example, treatment तो हो गई, prehabilitation हो गया, rehabilitation हो गया, सब हो गया, but patient is terminal. Patient is, in a lot of pain, is almost probably bedridden, probably cannot move much. So the motivation is very less. The the mood of the patient is constantly sad, and there are a lot of emotional upheavals, or you can say instability a lot of times. So we guide them during their terminal part as well. Ki terminal abhi hai, to how to handle it. So we teach them acceptance, that they have to accept what is going on, and acceptance say जो होगा, that is their half of the problem will be solved, that if they just accept that okay, this is how much I have lived, and we try to tell them, we try to go through their history, we try to ask them कि उन्होंने जिंदगी में क्या क्या किया है, and that way we tell them कि you see, you have achieved this, you have achieved that, you have done this, you have done that, so why are you so worried? Even if life ends here, you have done so much at this particular point of time. So हर एक के लिए अचीवमेंट का डेफिनेशन इज वेरी डिफरेंट. फॉर समबडी इट मे बी कि जब तक मैं नोबेल प्राइज नहीं जीत लेता तब तक मैंने टर्मिनली सिक नहीं होना चाहिए. किसी के लिए द डेफिनेशन कैन बी आई नीड टू हैव एटलीस्ट अ स्मॉल फैमिली, मी माई वाइफ और मी माई हस्बैंड और माई पार्टनर एंड वन और टू चिल्ड्रन, और मे बी किसी का रहता है आई शुड बी एबल टू सी माई ग्रैंड चिल्ड्रन एंड देन पास अवे. तो किसी के लिए अचीवमेंट ये भी रह सकती है. सो अचीवमेंट की डेफिनेशन कैन डिफर एंड यू नीड टू आस्क देम लाइकवाइज कि आपके हिसाब से क्या क्या हुआ है आपके लाइफ में, व्हाट हैव यू अचीव्ड, लाइक व्हाट वर योर गोल्स एंड आप कितना आगे तक आए हो. एंड दैट इज हाउ वी मोटिवेट देम कि सी यू हैव अचीव्ड दिस मच, सो it's good for one lifetime. So that is that. Then टर्मिनल काउंसलिंग के बाद बहुत बहुत इंपॉर्टेंट एक चीज हम लोग बार बार भूल जाते हैं कि सिर्फ कैंसर पेशेंट्स की काउंसलिंग ही काउंसलिंग नहीं है. इट इज वेरी इंपॉर्टेंट टू काउंसल देयर केयर गिवर्स, बिकॉज केयर गिवर्स ऑल्सो सफर अ लॉट while providing the care. So prehabilitation stage में, rehabilitation stage में caregivers का suffering is quite a lot. So we need to even guide the caregivers how to take care of their own health, their own psyche, not to get upset. बहुत बार ऐसा हो जाता है कि अरे मेरे पेशेंट का या मेरे रिलेटिव का whosoever is going through cancer, today the patient coughed up blood, and probably for us it might just be one episode जिसमें हम लोग इतना बॉदर नहीं करते, but for the caregiver it's a huge thing. My patient coughed up blood, now what will I do? Probably this is a bad sign, probably the patient is terminal, probably the patient is going to die, probably there is no tomorrow, such things. And caregivers also suffer from not taking care of their own health, because they can generally, it happens that while maintaining the hygiene of the patient they cannot maintain their own hygiene. While maintaining the proper quality of life of their patient, maybe cooking them good food, giving them good nutrition, taking them for physiotherapy, taking them for counseling, they forget about their own exercise, their own nutrition, their own psyche. So that is another important aspect of counseling that comes into picture. Then, say for example, if the patient passes away, okay, then what comes into the picture is a very, very important thing, that is bereavement and grief counseling. Bereavement means कि जो दुख आपको होता है, जो डिप्रेशन आपको होता है आपके लव्ड वन के गुजर जाने से, दैट इज bereavement. So bereavement and grief counseling, grief मतलब दुख, okay, so bereavement and grief counseling करना बहुत जरूरी होता है, because as we say there are 5 stages of grief and the patient goes through, the caregiver or the close family member or a close friend or a partner or a spouse or children, whosoever may go through all the 5 stages, and we need to do counseling throughout those 5 stages. So that is another important aspect of post terminal or post death of the patient. Then a lot of time during rehabilitation we also have to do compliance and adherence counseling, you may say, because a lot of times क्या होता है कि पेशेंट इतना होप खो देता है कि बार बार पेन हो रहा है, बार बार एक्स एंड पेन्स हो रहे हैं, बार बार मे बी दे मे हैव सम अदर सिम्टम्स, और काफी बार ऐसा होता है कि रिपीटेड टेस्ट कराने वो लोग जाते हैं, ब्लड टेस्ट रिपीटेड कराने जाते हैं, या मे बी पर्टिकुलर जो भी उनको टेस्ट प्रिस्क्राइब रहते हैं वो कराने जाते हैं, एंड दे सी अ डिटेरियोरेटिंग पैटर्न इन देयर टेस्ट्स, सो दे स्टार्ट लूजिंग होप, एंड दैट इज द रीजन दे डिसाइड कि जाने दो, अब मरना ही है तो अब करके कुछ मतलब नहीं है, and then they are not compliant with their radiotherapy, chemotherapy, medication, whatever is given to them. So it is very important that we do compliance and adherence counseling to help the patient be motivated, keep their hopes alive, and we need to guide them throughout every test as well कि ये टेस्ट का रिजल्ट ये आया है इसका मतलब ये नहीं है कि कल के कल आपको कुछ होने वाला है. So we need to tell them as per the medical knowledge as well कि you don't need to worry. अगर आपका क्रियाट से फॉर एग्जांपल 5 से आज 7 हो गया है इसका मतलब ये नहीं कि कल चल के 10 भी हो गया तो आप एकदम सडनली कुछ आपको बहुत सिवियर हो जाएगा. So you need to guide them accordingly कि don't worry, there are other things that we can do. There is a list of options that we have. There is a menu that we can serve you with. You can choose and we can tell you the pros and cons of everything. So don't worry is the an important message. और साथ ही साथ आई वुड से फैमिली काउंसलिंग रहती है, ग्रुप काउंसलिंग रहती है, सपोर्ट ग्रुप काउंसलिंग रहती है. सपोर्ट ग्रुप काउंसलिंग एक्चुअली हेल्प्स अ लॉट if during the rehabilitation stage, say for example we have a group of 8 to 10 cancer survivors, okay, and we are doing group counseling, it helps a lot. It's almost like पकड़ के चलिए AA की जो मीटिंग होती है ना सपोर्ट ग्रुप, जैसे अल्कोहलिक्स एनोनिमस जिन्होंने अल्कोहल पीना छोड़ दिया है एंड नाउ दे आर इन रिकवरी. अब वो लोग साथ में एक सपोर्ट ग्रुप फॉर्म किए हैं. दे टेल देयर ओन स्टोरी, यू नो, कि जब मैं अल्कोहल पीता था तब ऐसा होता था बट नाउ हाउ माय लाइफ हैज इम्प्रूव्ड, थिंग्स लाइक दैट. आई एम दिस ईयर सोबर, दिस मंथ सोबर. सिमिलरली ऐसे ही वी फॉर्म सपोर्ट ग्रुप्स ऑफ कैंसर पेशेंट्स जिसमें they can tell about, you know, their story, their prehabilitation stage, their recovery stage, their rehabilitation stage, the pain they are undergoing, and whatever they are undergoing basically during the current point. And then they can discuss amongst themselves, and that is how उन्हें ये एक फीलिंग आती है कि मैं अकेला नहीं हूँ, मेरे साथ ये भी है जो 10 साल से कैंसर सफर कर रहा है, मेरे साथ ये भी है जिसको अभी 2 दिन पहले जस्ट डायग्नोसिस हुआ है. एंड इमेजिन जब मेरा डायग्नोसिस हुआ था तब मैंने कैसा रिएक्ट किया था. सो यू कैन गाइड एज वेल, आई मीन यू कैन बी समबडी स्पॉन्सर एज वेल, प्लस यू कैन ऑल्सो बी हेल्प्ड बाय अदर पीपल कि आप अकेले नहीं हो, दूसरे भी है जिनके साथ ऐसा ऐसा हो रहा है, and you are not alone in this journey, and this journey you can take together. So I think all these things come in rehabilitation counseling. I may be missing out on 1 or 2 counselings maybe, or psychotherapies, but I think I've covered majority. Back to you, Dr. Day, the moderator of today.
so, so another thing which is coming up is that along with the support group, we also are having what you pointed out is that we need peer support also. Peer support
Yeah.
means in the form of other patients. So we have these things called laryngectomy clubs. Okay. So a patient who has undergone a total laryngectomy doesn't know how to speak. We fit him with a device called tracheoesophageal puncture, tracheoesophageal prosthesis, where he occludes his, the stoma, and he can learn how to talk. So in what happens is there are the this laryngectomy club consists of other patients who have also undergone laryngectomy at different stages of time, have undergone the challenges which they have come across in developing speech again. It's almost as if you are learning to talk again in life, and it's something which is a very challenging thing, something which they do it on their own. And sometimes this peer support is so important that they actually uh, teach someone new in the group that you're not alone, we are there. And this, I think, encourages the patient a lot. It is both therapeutic as well as it's also giving patient the strength and hope that you're not alone. So yeah, I think we have covered most of the points in rehabilitation and yes, nutrition and everything. And I think yes, it was a good chat, Surabhi.
Yeah, I also think so.
It was a good chat. We should catch up again sometime.
yes, on some other topic, and again have such good discussions.
Absolutely, absolutely. Because sometimes we should also talk. Instead of having a very. That's why I told you that we should have a very informal chat where we we have a lot of things to say. Which we address our concerns and everything. So yes, this was a very good. Pinak, thanks for joining.
Yes, sir. Yes.
Yeah,
Thank you
you
for
have to wind up.
involving me as well.
Uh huh.
Thank you for involving me as well.
Yeah, yeah, sure, sure.
Very nice meeting you.
Same here, Dr. Pinak. Okay, so I think we can wrap up our session. और जो आखिरी में मैं हमेशा बोलती हूँ, that is for such good content, do follow us, and for such good content, just sorry, like, subscribe, and comment, and basically comment as to what more you would like us to cover. We cover such good topics, we bring in such good speakers who are knowledgeable, so we will continue with the same regimen, and you let us know through your comments as to what you need, and definitely do subscribe to our channel, and yeah, we'll be back soon. So have a good Saturday night, enjoy. You're muted.